Good evening, everyone, and welcome to tonight's webinar on advancing myopia management, its tools and techniques. My name is Dr. Duru Franklin. I will be your moderator for tonight's session. We are excited to have Dr. Obinwanne Chukwuemeka Jr. In joining us tonight to share his expertise on myopia management. I'll be giving a brief biography of Dr. Obinwanne Chukwuemeka Jr. Dr. Emeka is the head of Cornea Specialty Contact Lens and Myopia Management Department. Dr. Emeka's interests include anterior segment diseases, keratoconus, myopia, specialty contact lenses, and the ocular surface. He received his Doctor of Optometry degree from the University of Benin, Benin City. He also completed a fellowship in cornea and anterior segment from the L.V. Prasad Eye Institute in India. He is a fellow of the American Academy of Optometry and is the first Nigerian to become a fellow of the Scleral Lens Education Society USA. He is also a member of the Optometry Scholars Academic Forum. Dr. Emeka is an ambassador for the Tear Film Ocular Surface Society (TFOS) to Nigeria and served on the Societal Challenges Committee of the TFOS's Ocular Surface Disease, a lifestyle epidemic workshop held in Sicily, Italy in 2022. Dr. Emeka is also a certified myopia management expert. Dr. Emeka is involved in clinical research projects focused on scleral lenses, keratoconus, childhood myopia, contact lenses, ocular surface disease, and cornea. He is also involved in international research team projects, white papers, and meta-analysis with notable organizations such as the American Academy of Optometry, Cochrane Eye Vision Research Group. He has extensive experience in cornea, specialty contact lenses, and myopia management. I'm very excited that we'll be learning a lot from Dr. Emeka today. So before we begin, I would like to remind you all to mute your mics as you join in, and you can put off your video or put it on if you wish. I also recommend that you ask questions using the chat box. We'll also have a question and answer session at the end of the presentation. All questions and contributions will be taken at the end of the presentation. Without further ado, please join me in welcoming Dr. Obinwanne Chukwuemeka Jr. Dr. Emeka, sir, you're welcome. Please go ahead and begin your presentation. We are all eager to learn from your expertise, sir. Thank you.
Complications that can result in pathological changes at the posterior segment. Typically, this is associated with an axial length greater than 26 millimeters. However, there are studies that still show from about 25 millimeters upwards, we start to see some pathologic changes. Now, why the distinction for this definition is important is because you could have a -2 diopter myope who has pathological changes at the back of the eyes, and we will consider that pathologic myopia. And you can have a -6 diopter myope who has high myopia but no pathological changes. So you need to make the distinction between high myopia and pathologic myopia. High myopia is a risk factor for developing pathologic myopia, but they are not the same thing. We'll talk more about that as we go on. Now, I'm sure all of us have seen that staggering statistic that by 2050, half the world's population would have myopia. And we know that in East Asia, like in China, Taiwan, Singapore, the prevalence of myopia is quite high. Whereas in Africa, for example, in Ethiopia and Tanzania, it's about 6%. A recent meta-analysis that was done by Obinwanne and his group in 2022 put the prevalence of myopia in school-age children at about 4.7%. Another group took it a step further, Kobia and his group in Ireland, and they projected that by 2050, 17% of African school-age children will have high myopia. So look at the jump. We're in 2025 now, and 2050 is about 25 years from now. What this means is we will likely have 3 times the amount of myopia that we currently have now in school-age children. So those of you who work in urban practices, you would agree that you tend to see more myopes these days than you used to see before. And we tend to have more progressive myopes or children with myopia in rural areas compared to those, in urban areas rather, compared to those in rural areas. So if you keep in mind the increased digitization, if you keep in mind the fact that our life is becoming more isolated, more indoor time, less outdoor time, poor sleep pattern, we would likely exceed the 17% by 2050. Now, in Nigeria, the investigating studies show that myopia prevalence is about 2.7% and ranges to about 4.8%, depending on the study that you're looking at, depending on the definitions that were used in the study, and depending on the criteria used in defining myopia in the studies. I already talked about the prediction by the Brian Holding-Etal paper that came out in 2016 that basically put myopia management on the map. Because this study said that by 2050, half the world's population will have myopia. But what's more worrisome is that 500 million of that half of the world's population that have myopia will develop high myopia. And as I mentioned in my beginning slide, high myopia is associated with pathologic myopia. So what that means is we would likely see myopia becoming a leading cause of severe visual impairment and blindness by 2050, or maybe before then, because it's already happening in East Asian countries. Now, here are some things that I like to talk about before I start diving into myopia management lectures, just something that as practitioners we should think about. When we see patients, especially children, pediatric patients who have myopia, and it progresses, does it bother you? A lot of times you have parents, guardians, or even the patients themselves, they would ask you, has my prescription increased? And when you say yes, they start getting worried and ask you, what can we do about this increase? What can be changed? What can be adjusted? And another thing that you would often find is you need to ask yourself, when you see patients who have myopia, do you think that you are providing the best form of management in terms of clinical practice to that patient when you do not incorporate myopia management? And are we aware that when we manage patients with myopia, you're not just improving their vision, but also improving their quality of life? Now, lastly, this is sort of a scenario I'd like to paint. When we see patients who we diagnose with glaucoma, and we see the large cupping, we see the raised intraocular pressure, we do OCTs and we see thinning of the retinal nerve fiber layer, we see thinning in the ganglion cell complex, we see in central cornea, we see visual field defects, we see all those things. Do we wait for the glaucoma to worsen or for the glaucoma to progress before we start to institute therapies to manage the glaucoma? Or do we look at the risk factors that this patient presents with now? Thin corneas, family history, thinning of the RNFL, maybe raised pressures, maybe not raised pressures, maybe visual field defects. We look at these risk factors and we determine that if we do not step in, the glaucoma gets worse. But why is it that when it comes to myopia, we act differently? We see a child who is very young. We see a child with family history of myopia, whose parents may even have pathologic changes at the back of the eye associated with myopia, like glaucoma, cataracts, retinal detachments, and so on. We see a child who spends a lot of time on digital devices, less time indoors. We see all the red flags. Yet you want to wait until the myopia progresses significantly before you start myopia management. How does that make sense? Now, the reason why this last statement is important, I'm just going to skip my slide and go down to something that I think touches on everybody. Just give me a minute. Yeah. Now, the reason why this is important is because I and a group of colleagues, about 2 years ago, we came together and we had done a survey of eye care practitioners across 23 countries in Africa. And what we found was that over 60% of the eye care practitioners, despite being aware of myopia management, did not practice any form of myopia management. Most of the eye care practitioners that we surveyed still prescribe single vision spectacles and contact lenses to patients whose myopia were progressing. Less than 10% of eye care practitioners in Africa did prescribe some form of myopia management. Nearly 30% of the eye care practitioners cited that cost was the main reason behind not embracing myopia management. So if you look at what I said in terms of how we delay myopia management and we look at the current practice, a lot of us are aware of myopia control options, yet we still do not embrace it. So that's something that you need to answer for yourself, why you still delay in managing myopia in your practice, or maybe referring to a colleague who does. There are certain myths associated with myopia. Some of these come from eye care practitioners, some of these come from parents. So the first thing would be that we may think that if you delay the correction of the refractive error, the eye may emetropize, and then that way myopia doesn't fail. That is false. Now, that's something that I've heard a lot of people say, but it's not true, because by the time the eye has become myopic, emetropization has failed. And you waiting would only increase the chances of amblyopia, decrease the quality of life of that child, and may also worsen the progression of the condition. Now, wearing glasses, this second point will be that wearing glasses makes the eyeball look small. That's just because when you wear glasses for myopia, it's a minus lens, so it causes minification of the image. So the eyeball looks smaller, but it's not really small. This next point is something that was controversial initially. However, we now know the real answer to it. The idea that if you undercorrect myopia, it will decrease myopia progression. This is false. We have looked at studies that have looked at undercorrection as a means of myopia control. We have looked at studies that have even looked at overcorrection of myopes, and we know that undercorrection or overcorrection is myopogenic. What that means is it will worsen myopia progression. So you want to give the optimal cycloplegic refraction as the form of visual improvement and incorporate myopia control strategy. This point is something I like to say all the time. If you give single vision glasses or you give single vision contact lenses, you're not doing myopia control. You're just improving somebody's vision. That's it. Now, sometimes you may hear that if one parent is myopic, there's a risk one of the children will become myopic. That part is true. That's not a myth. Now, building on that last point, we know that if one parent is myopic, there's a 3 times chance that one of the children will have myopia. And we often tend to see kids have higher amounts of myopia than the parents whom they inherited it from. We also know that an increase in lack of accommodation beyond 0.75 and associated near isophoria may be a risk factor for myopia progression in children. We know that infants who sort of emetropize too quickly become myopic later in life. Now, the idea is what we term hyperopic reserve. Now, when a child is less than 7 years of age, we expect you to be hyperopic by more than +1 diopter. So when you do your cycloplegic refraction for a child, and let's say the child is 4 years age or 5 years, if the child has less than 1 diopter of cycloplegic refraction, that child is at risk of developing myopia. And the idea is this: when a child is born, they are hyperopic. As the eyeball grows, the axial length increases, and that hyperopia reduces. If they begin with less hyperopia to start with, they approach emetropia very quickly, but the axial length is not done increasing. So it continues to increase as the child grows, and they move from the early correction of the hyperopia to emetropia, then to myopia. So a cycloplegic refraction of less than +1 diopter before the age of 7 is considered a risk factor for developing myopia later in life. children who spend more than 2.5 hours daily outdoors, or less than one, who spend more than 2.5 hours daily on near work or digital devices rather, and less than 1.5 hours daily outdoors will likely develop myopia. When a child is born with conditions that obscure the retina, for example, congenital cataracts, ptosis, we know that this can cause myopia progression. Now, this has been proven for many years, and there are studies by Professor L. Smith and his group where they had tried this in rhesus monkeys, in chickens as well, where they breed the chickens in an environment where they occlude one eye, either by placing an opaque contact lens on the eye or suturing the lids of the chicken or the monkey together. And what's been noticed is the eye that's occluded, the axial length increases beyond what is considered normal and leads to myopia. The eye that's open, the axial length does not increase as much, and the vision, the myopia does not occur in that eye. We also know that sleeping late in school-age children has been associated with myopia development and myopia progression. The exact cause is not known. We'll explore some of the theories later as we go on. But we know that children who get less than 9 hours of sleep per day and children who spend more time on digital devices towards the sleep period tend to have alteration in their circadian rhythm, the levels of melatonin in the body, and consequently changes in the dopamine on the level of the retina, and that can lead to axial length increase. So just to summarize what we've talked about, we've seen that when a child has an onset of myopia less than 9 years of age, they will likely progress fast. Less plus refractive error by the age of 7 is a risk factor for developing myopia as you go on. Parental history of myopia is a risk factor for developing myopia. Children who are from the East Asian ethnicity tend to have myopia more. Children who spend more time on digital devices and less time outdoors are at risk of developing myopia. Now, typically, myopia complications goes beyond just the inconvenience of not seeing things from far. Think about most of the patients in your practice who you have funny looking retinas. A lot of them have myopias. Myopia is associated with something called myopic maculopathy. As the level of myopia increases, the axial length increases. As the axial length increases, the choroid becomes thinner. As the choroid becomes thinner, those degenerative changes that occur in the choroid, because the macula is such that it's thinner than the fovea area is thinner than other areas of the retina, it's prone to certain forms of degeneration that involves stretching. And we term that myopic maculopathy, which has 4 categories. The first category is something we all see a lot, but we do not realize that that's myopic maculopathy. Diffuse tessellation of the fundus in a myopic eye is the first category of myopic maculopathy, followed by chorioretinal scarring, lacunar cracks around the Brooks membrane in the macular area, which extends the chorioretinal scarring, causes thinning, and then consequently posterior staphyloma, which will be considered category 4, with any plus signs, which will be lacunar cracks, other pathological changes that you might find. Now, if you realize that the first stage of myopic maculopathy is the diffuse tessellation of the fundus, if you go back to the way we looked at the fundus in Myo, and you've looked at the back of the eyes, you would also notice, sometimes you notice some funny looking things that look like scars, could be retinal lattice degeneration, could be angular streaks, could be different things. You're not sure what those things look like, but you tend to not find a lot of these things in people who are not myopic. I mean, you may see, but you would likely notice that you tend to see it more in myopes. Now, the next thing is glaucoma. Now, a lot of times when you're in clinical practice, there is this patient that for the life of you, you cannot tell whether this person has glaucoma or not. You're looking at the back of the eye, the disc looks cupped. Sometimes the disc may be tilted. You might see papillary retinal atrophy. Pressures are normal. Maybe there's no family history, but this patient has myopia. And those are the ones we often leave hanging as glaucoma suspects, and we keep monitoring. Now, that's been classified as something we call glaucoma-like optic glaucoma-like myopic optic neuropathy. So it's a distinct form of optic neuropathy that's peculiar to myopes that looks like glaucoma, puts them at risk of developing glaucoma, but it's not glaucoma. Also, cataracts. We know that individuals who have myopia are likely to develop cataracts as well. And then retinal detachment. But there's also the mental health aspects to myopia that we don't often talk about. In fact, if you know myopes right from your maybe primary school or secondary school, you would often remember that they tend to keep to themselves, they don't socialize much, they play around their immediate environment, because it does cause some form of decreased confidence, whether it's because they're wearing spectacles or they're being teased by friends or bullied by people in their schools. Also, there's the financial burden that it puts on the patient or the parents who pay for these interventions for myopia management. Now, we cannot discuss myopia management without talking about the concept of peripheral hyperopic defocus, which was popularized by Professor L. Smith and his group. Now, typically, when we give someone single vision spectacles or contact lenses, what we are doing is moving the image focus at the central part of the retina, which is the fovea, to give clear vision. But the retina is not flat, it's curved. So if you improve vision and focus the image at the central part of the retina, at the periphery of the retina, because the image profile that you put is straight, but you have a curved retina, image is clear because you move the focus to the central part of the fovea, but in the periphery, you have the image behind the eyes, which we consider relative peripheral hyperopic defocus. Now, the idea is the brain tells the eyeball to correct that hyperopic defocus in the periphery, move the axial length backwards to correct that peripheral hyperopic defocus. Now, when the axial length has to move backwards to correct peripheral hyperopic defocus, what ends up happening is the myopia progresses. What do? We give another single vision glasses, the peripheral hyperopic defocus reoccurs, the retina, the axial length continues to elongate to correct that. What the optimal form of correction should be is give central clear vision, but correct that peripheral hyperopic defocus to take away the optical stimulus to axial length increase, and that way we counter myopia progression. Now, in clinical practice, what are some of the tests that would need to be done to counter myopia progression or to actually manage a child or an individual with progressive myopia? So these are basically, think of them as information gathering. What you would need to gather to establish a risk profile for the patient to determine the management option or the tool or the technique you would use in managing their myopia. The first is obvious, refraction, but emphasis on cycloplegic refraction. Remember, we do not want to undercorrect because that causes myopia to increase. We do not want to overcorrect as well, because aside from the asthenotic complaints associated with that, it's also myopogenic as well. The next is keratometry and corneal topography. Now, keratometry is important because if you look at, if you've been privileged to be involved in maybe myopia research or even refractive error research, where you monitor children from a young age, as then you get older, you see the changes that occurs, you'd often see that change in the axial length, in the keratometry values and corneal curvature rather. So typically what happens is kids are born, small eyes, stiff corneas. As they grow, the axial length increases, the cornea flattens. Now, aside from the keratometry helping you out with ruling out whether this myopia may be due to a secondary cause like keratoconus, keratometry also is important when you're going to fit contact lenses for myopia management. Corneal topography is extremely important if you're going to use orthokeratology as a method for myopia management as well. But it's also important to rule out secondary causes of myopia like keratoconus, because you're not going to be managing a keratoconus patient with myopia control strategies, because they're different entities, different diseases. Slit lamp examination, obviously, of the anterior segment and the posterior segment is important, but dilated fundus examination is very important because you want to not only have a clear view of the posterior pole, but you want to look at the periphery of the retina so you can pick up things like lattice degenerations, maybe horseshoe tears, lacunar cracks, angular streaks, chorioretinal scarring, white without pressure or white with pressure in the periphery of the retina. you would need to have the eyes dilated, and preferably with a stereoscopic view, so you're looking with both eyes. It is typical that you might find this difficult to do with kids, but here's some tips that I'll give. One, don't be the person dilating the child, because children, after they've been dilated, they have this hostile behavior towards whoever put the drops for them. So you want to assign this to maybe an assistant, an intern, a technician, or even the front desk, somebody who's not the main person who's going to do that examination. If you want to be the hero and swoop in it and be like, oh, they put the drops for you, come, and then make the examination fun, but get the details, the data that you want as quick as possible. And if you still find it difficult assessing the periphery of the retina or carrying out your refraction, you could do a cycloplegic automated refraction if you're not able to do retinoscopy. You could also, if you have fundus cameras that's able to image the periphery of the retina, that would also be helpful. Wide field fundus cameras. Axial length is extremely important in myopia management. In fact, we are now thinking of axial length as the benchmark for determining myopia control. Because if you're looking at refraction, you're just looking at only one piece of the puzzle. And another thing that I've seen over time clinically is sometimes we may see somebody who's maybe a -2 or a -3 and think, the myopia is not that bad. But you're looking at the back of the eyes and you're seeing pathologic changes that you would expect to see in someone who's about -6, 7, 8, 9, 10. But this person is -2.5 or -3, and I've seen several of these kind of cases. The answer is in the axial length. You check the axial length and you can see that they're about 26, 27 mm. So if you're looking at only the cycloplegic refraction, you're just looking at one piece of the puzzle. Now, another thing that would be a plus to have, it's not compulsory that you have it, but if you do have it, use it, would be the OCT. Now, the important thing with the OCT is it gives you a cross-sectional image of the retinal tissue and the choroid. And also those patients who you sort of suspect may have glaucoma-like myopic optic neuropathy can actually image their optic nerve heads, the RNFL, and monitor these patients over time. What you may notice is if the myopia does progress, the RNFL becomes thinner, putting them more at risk of developing glaucoma. Also for the choroid, we're beginning to think of the choroid as not just that vascularized structure that sits underneath the retina and supplies it with nutrients, but also it could serve as a biomarker for telling you whether myopia control interventions are working or not. For example, we know that the choroid gets thicker when you use low-dose atropine for myopia management. We also know that the choroid gets thicker when the patients wear orthokeratology lenses. So there is something, some receptors or changes that occurs in the choroid that does interfere or is associated with myopia management. But exactly how this works, we're not 100% sure yet, but we know that this does happen. Now, the last part will be the binocular vision aspect. A lot of times, we think that we just give myopia control strategies without considering their effect on binocular vision. But it is important, extremely important, that we consider the effect of binocular vision on the strategies that we intend to put in place. So if you're seeing a child with an obvious binocular vision issue, you might want to address that binocular vision issue first before commencing myopia management. Or if the strategy that you have decided to use for myopia management will address the binocular vision issue side by side, then great, go ahead for that. For an example for this would be a child who has ISO deviation or isophoria. Obviously, when they are moved to contact lenses, there's less accommodative demand for somebody who's wearing plus lens, for example, who's hyperopic, for example. So that will cause a bit of exhaustion. But for a myope, when you move from spectacle to contact lens plane, there is more demand on accommodation. However, if that myope is being fitted with a multifocal contact lens, which has an addition, that addition will decrease accommodative response, and that decrease in accommodative response will straighten the eyes. Also, for kids who've been on low-dose atropine, we now have data that shows that prescribing low-dose atropine has a slight ISO shift that it causes. It increases isophoria a little bit. Now, that's slight increase in isophoria may be beneficial for a child who has myopia and intermittent exodeviation. So the ISO shift will address that. Now, some pointers that you can look at is during your cover test or von graph or whatever method that you use in assessing binocular ocular alignment in kids. Also, dynamic retinoscopy is extremely important, not just to determine the risk factor, because we know that children who have a high lag of accommodation, that's more than +1 diopter of accommodative lag, are at risk of developing or progressing when they have myopia. We also know that the lack of accommodation actually helps us determine the amount of addition we're going to put in spectacle forms if we're using progressive addition or bifocal lenses for myopia control, which we'll talk about later. Other tests you could incorporate with stereo acuity, especially when the child has anisomyopia and things like that. Yeah, I already talked about retinal OCT, but that's just an image of me measuring the choroidal thickness in this child who has myopia. Now, why is axial length important? Now, axial length is not only important because you want to look at this patient's risk of developing myopia-related complications. As I said before, we consider an axial length more than 26 millimeters, indicative of pathologic myopia. But we know that an axial length of more than 25.9 mm will put you at risk of developing myopic maculopathy. An axial length of more than 26.5 millimeters will put you at risk of developing glaucoma and RNFL changes. Now, the normal axial length for the average child would be about between 23.5 to about 23.6 millimeters. Now, here's the thing with axial length. Very tiny changes in axial length will lead to big changes in refractive error or myopia progression. So if you have a child who, for example, was 24 millimeters when you first saw them in terms of axial length, and then that increased to 25 millimeters, that's just like 1 mm change, right? But there's a study that we had done. This was published in 2024, but I mean, we did this study in 2023. And what we found was that for Nigerian children, at least, for every 1 mm change in axial length, it corresponded to 2 diopters of myopia progression. And we also found that for every 1 mm change in axial length, there was approximately 16 microns thinning in the choroidal level. So your axial length does not only just tell you risk factors, it can also tell you how much myopia progression you're likely to expect by looking at the change or the difference between the axial length over time. But also, if you're using orthokeratology as a method of myopia control, axial length is actually the only reliable way for you to determine progression, because in orthokeratology, what you're doing is moving that patient from myopia towards emetropia. So when myopia does progress or when there are changes, it'd be difficult to know because you have already altered the refractive error of the eyes using orthokeratology. So the reliable way that we determine progression in children using orthokeratology for myopia control is by the axial length measurement. Now, generally there are 2 ways. Either you're going to use the ultrasound or optical method. The optical method is obviously better in terms of better repeatability and more reliable findings. But if you have the ultrasound biometer, which is what I personally have in practice, and you know how to get reliable results from it, keep your hand steady, get cognition from the child, it's also an extremely useful tool. Now, I already talked about this slide because keeping all the information we already heard and looking at the results of this survey, it's important that we're having talks like this or lectures like this to indicate why myopia management is important, because most African eye care practitioners actually know about myopia management, over 60% of them. However, still that same percentage, we are prescribing single vision glasses or single vision contact lenses to patients whose myopia was progressing, despite having the knowledge of myopia progression. Now let's dive into the tools and techniques that we can use for myopia control. Again, I'd say single vision spectacles, single vision contact lenses is not myopia control. You're improving vision, yes, but you're not controlling myopia. Now, there's been studies that dates back to the mid part of the 2000s, I think 2006, 2010, that shows that executive bifocal lenses actually has some form of myopia control. And to take it a step further, incorporating prisms in the addition portion has an added advantage in terms of myopia control, which we'll talk about later on, and when to do that. Also, progressive addition lenses have been shown to give some form of myopia control, quite weak compared to executive bifocals, obviously because the executive bifocals will have a large add area. Now, that large plus, aside from taking care of maybe the accommodative lag that that patient may be having, it's also taking care of the peripheral hyperopic defocus in the superior portion of the retina. Whereas a progressive addition lens has a small addition zone and takes care of small amount of the accommodative lag, small amount of the peripheral hyperopic defocus on the superior part of the retina. Now, taking it a step further would be the myopia defocus lenses. There are different designs from different companies, but they all have one thing in common: addressing hyperopic defocus in the periphery. The HALT lens, for example, that's a highly spherical lens-led technology from Essilor, has a clear central single vision center with defocus around it in forms of rings. Now, this defocus are a series of small, tiny plus lenslets that creates a volumetric defocus within the eyes to cause correction of hyperopic, but also induce peripheral myopia in the periphery of the retina to prevent the optical stimulus of axial length increase. The same idea for the DIMS MyoSmart lens. The DIMS MyoSmart lens also has a central 9 mm clear zone, and in the rings or the periphery, you have small lenslets that's about 1 mm in diameter and about 3 diopters of plus power in each of those tiny lenslets. Zeiss also has the Myocare lens, which has the cylindrical refractive elements. Now, the cylindrical annular refractive elements in the Zeiss Myocare lens has plus power that ranges from plus 3.8 diopters to plus 4.8 diopters in each of the lenslets. Now, if you pick the lens, it will look something like this: clear zone, small rings around it, with each of these rings having tiny lenslets that have plus power that corrects the peripheral hyperopic defocus, and that's how it does myopia control. Now, what's important is in Africa currently, we do not have the DIMS. We do have the Myocare Zeiss, at least in Nigeria, it's available. I think Stellest is available in South Africa. We're still hoping it comes to Nigeria soon. They just released the 5-year data and showed fantastic myopia control. I will say this much: for patients who have put on the Myocare spectacle options, they do well, and I've not seen any progression so far, touch wood. I also prescribe executive bifocals and progressive addition lenses as well, whenever indicated, but we need to keep in mind that those are at the bottom hierarchy of myopia management. Now let's dive into the spectacle options, because sometimes where you practice, you may not have access to maybe Myocare or Stellest or the MyoSmart lens or any of those funky or fancy myopia control spectacle options, and you want to do your good old-fashioned bifocal lenses. Now, the add power in the bifocal lens, aside from compensating for the high lag and near ISO, also addresses a bit of peripheral hyperopic defocus in the superior retina only, because it's not a 360 thing. The add is just a one portion. And the indication for using bifocals in children who have progressive myopia will be a child who has a high lag of accommodation. So you would have done dynamic retinoscopy and you would see that the lag of accommodation is more than +1, and they have a near isophoria. Now, the two do not have to be present for you to say this person is indicated for using a bifocal lens. If you have one, for example, near ISO or a high lag of accommodation, the child is likely going to benefit from an add in a bifocal. Now, what add do you use? Typically, what's recommended is taking 0.5 diopters away from the lack of accommodation and prescribing that in form of the ad. So let's say I have a child who has a lack of accommodation of 2 diopters when I do the dynamic retinoscopy. I will be prescribing plus 1.5 diopters. If the child has a lack of 1.5 diopters, I'm prescribing an ad of plus 1. However, most clinical trials that have been done for myopia control using bifocals use an ad of 2 diopters. So that's usually what everybody prescribes, plus 2 for myopia control when given bifocals. You want to lift segment height a bit upwards when you're prescribing bifocals for kids so that when they're doing near work, they're forced to look through that ad portion. And also, the wider the near zone, the better myopia control effect you're going to get if you're going to use that. And also for kids who have low level of accommodation or near exo, you would want to incorporate basing prisms to help give you better myopia control. Now, the reason why this is important is because the reason why we're talking about this is we know that in Africa, we do not have all the spectacle options available. Currently, at least in Nigeria, there is the Myopia lens, but that too might be out of reach financially for some patients. So you can still fall back to your bifocals as a method of myopia control. You also need to keep in mind, just as we've seen from this guideline, that prescribing bifocals, we need to keep the binocular vision in mind when you're doing so. Now, on to more efficacious tools. We've talked about the spectacle options, bifocals, progressive addition lenses, and when to use and how to use. We've talked about the focus spectacle options like Stellest, Myocare, DIMS, MyoSmart, and Multiple. Now let's look at other efficacious options. Multifocal contact lenses. Now, there is the SEED multifocal contact lens. This is actually an extended depth of focus contact lens. So basically what that means is it's a center distance multifocal lens, but the ad portion is around the distance prescription at the center. And the near zone, or the central portion where you have a distance prescription is quite small. So it creates a pinhole effect with the ad that gives clear vision centrally, hyperopic defocus 360 to correct, myopic defocus 360 to correct the peripheral hyperopic defocus at the retina. But also because of that pinhole effect, improves the depth of focus and gives clear vision as well. The MySight lens, this is from Cooper Vision, is actually a daily disposable lens, just like the SEED lens. It's also a center distance multifocal lens. So what that means is clear vision at the central portion with an ad around it. The Blink study looked at giving multifocal center distance multifocal contact lenses to children for myopia control. So there was the Blink 1 that actually proved that when you prescribe center distance multifocal contact lenses to children, it does control myopia. There was the Blink 2 study that looked at what ad would be appropriate for myopia control in children. So there was the low ad group and the high ad group, and then the single vision control group. So what the study showed, children who were in the high ad group, an ad of plus 2.5 diopters in center distance multifocal contact lenses had better myopia control compared to the low ad group and the control group single vision contact lenses. There's also the natural view contact lens, which is a form of multifocal contact lens as well for myopia control. Then there's autokeratology. For autokeratology, this could be customized autokeratology, could be conventional autokeratology. Now, the beauty of using customized autokeratology is you can fine-tune the myopia management or treatment option you're trying to give that child to that child rather than using a generic conventional design. Personally, I have access to the Cooper Vision lenses, the Biofinity and Proclear multifocal contact lenses. I think a lot of us few of us may have used the SEED myopia control lens. This is also available in Nigeria and Africa. I also fit autokeratology lenses as well, but I do understand that autokeratology is sort of a specialty of its own. It requires further training, so you might need to refer to someone who does. I do it, and it's quite rewarding. It's a rewarding space to get into. But if you're going to dive into autokeratology, you must have a corneal topographer. If you don't have a corneal topographer, you can refer to a colleague the corneal to get the scans done, and then they come back to you and you go ahead and do your orthokeratology fitting. Also low dose atropine. Now, this is something that's received a lot of attention and we'll talk more about later on. But the last point will be combination therapy. So sometimes it's okay to combine atropine with bifocals, atropine with progressive addition lenses, atropine with multifocal contact lenses, atropine with orthokeratology. Now, some studies have shown a synergistic effect in that more myopia control may be achieved. Some studies have shown no change when you combine, for example, 0.01% atropine with orthokeratology. Some studies have shown there's no additional benefits with combining both. So you might as well just stick to maybe orthokeratology. Now let's dive more into contact lens prescription for children. Now, typically we advise a child be above 6 years of age, just so that they understand handling. It doesn't mean I haven't prescribed contact lenses to kids younger than 6. I have. It has to basically do with parental assistance, compliance, and the child agreeing for this. But another thing you need to understand is we oftentimes communicate with children as if they're not in the room, or we communicate about conditions relating to children as if they're not in the room. They may not understand the full gist of what's going on. But when it comes to certain interventions, for example, if you're going to prescribe spectacles, you're going to prescribe contact lenses, getting the child involved and speaking to them about this will often get you quite far. You would understand how much cooperation you would get when they get an idea of what you're trying to do. As I mentioned before from the Blink 2 study, the higher ad for center distance multifocal contact lenses gives better myopia control. That's an ad of 2.5 diopters. Now, oftentimes, we often worry that there will be compliance issues when children wear contact lenses. What we know from research and what we know from clinical practice is that fear comes from either the parents or from you, the practitioner, saying the child is too young and they shouldn't be fit with contact lenses. But research says otherwise. Contact lenses are actually safer in children compared to adults. And this is published in research. We look at, I think I have a slide on that, contact lens safety. But contact lenses are safer in children than adults. And the reason is simply because children listen to instructions when they're still at that young age. They take advice from you and from the older person. And most times, contact lens insertion and removal for children is done with the guidance of the parents. Enforcing hygiene, like washing hands before you insert the lenses, wash your hands before you remove the lenses, don't sleep, don't bathe, yada yada. All that happens with parental supervision. The problem starts to happen when the child is beginning to leave the teenage years and they're becoming independent. That's when the problem starts to happen. But for children, contact lens is safer compared to adults. There's a recent study, this will just be the last point on multifocal contact lenses. So the Blink study went on for 3 years. So they monitored kids who get fit with multifocal contact lenses, monitored their myopia for 3 years and found that it was very good for myopia control. Almost about 70-something% myopia control. But after the trial, some children stopped wearing the multifocal contact lenses. So they're still being followed up as part of the study. And what was found was that even after discontinuation of the center distance multifocal contact lenses, the myopia still did not progress in those who were wearing center distance multifocal contact lenses. So it means the impact of center distance multifocal contact lenses when used for myopia management persists even after discontinuation of the contact lenses, after it's been used for about 3 years. Now, for orthokeratology, I would still fit an orthokid above 6 years. What's recommended is from a range of minus 1.5 to about 6 diopters. This is what the FDA recommends. However, if you do customized orthokeratology or data-driven orthokeratology like I do, you're likely able to correct higher degrees of myopia. My record is about minus 8.5. That's the highest amount of myopia I've been able to correct with orthokeratology. And I mean, orthokerator can also be done for adults as well, but I'd say about 80% of individuals who have fit orthokerator lenses since 2016 are children. mainly children actually, and they tend to be really rewarding. Not just because you've taken somebody who maybe was a -3 or a -4 and was known for wearing glasses before. Now with ortho-K, they no longer have to wear glasses throughout the day because orthokeratology gives you clear vision throughout the day without glasses or contact lenses, while still giving you the myopia control effect. Now, the reason ortho-K gives the myopia control effect, or even the center distance multifocal contact lenses, the add portion around the center of it. So for ortho-K, this is an example, this is an image of one of my patients with an ortho-K lens on the eye. So this central portion we call the treatment zone is what gives clear vision. This add portion, or this pool of fluorescein we see here, causes mid-peripheral stiffening of the cornea, which would induce some pus that corrects peripheral hypertrophic focus in the peripheral. That's what gives the myopia control effect as well. Now, the thing with this is you can actually customize this treatment zone to suit the type of myopia that you're seeing. And also, we now have toric orthokeratology lenses, because typically we would say the ideal candidate for ortho-K would be a child who has less than 1.5 with the rule astigmatism and less than 0.75 against the rule astigmatism, basically because of centration issues of the orthokeratology lens. However, we now know that the toric orthokeratology, which basically takes into account the elevation data and the topography of the cornea and incorporates that into an orthokeratology lens, you can correct even more amounts of astigmatism. Go down to contact lens safety. As I mentioned before, contact lenses are safer to children compared to adults. And in several studies, it's been shown. But I'm just going to focus on the study that was done by Chukwuemeka Jr, where they had reviewed several papers that had looked at contact lens safety in children. I'll just read the conclusion. Now, in long-term clinical studies estimating complications associated with contact lens wear in children, the complication rates, which was 15 per 10,000 patient years for microbial keratitis, and 97 per 10,000 years for corneal infiltrative events, is similar to those in adults, but even lesser in children between the age of 8 to 11. So basically what this means is, first of all, contact lens, visually significant contact lens complications are rare, but they are even less in children. And this is simply because the compliance is better when they're children compared to when they get older. From the contact lens assessment in youth study, even though I've not put the reference for that here, but from that study, we saw that the only difference in reality is you are likely to spend about 30 minutes more teaching children below the age of 12 about insertion and removal of contact lenses than you're going to teach maybe a typical teenager or an adult. So the only thing it's going to actually take from you is spending more time. What I usually advise for that is create a separate appointment for a teaching insertion and removal. You could delegate that responsibility as well. But contact lens, if people who've maybe been to my practice or have worked with me, will see that more than half of my contact lens wearing patients are children, and they make the fantastic patients because their compliance is usually very, very good. But when contact lenses are prescribed to adults, we usually would have to worry about them listening to the instructions you give them, or sometimes they don't listen and they tell you, oh, I'll be wearing contact lenses, and then something happens. For atropine, now we have known for many years. It's not just a recent thing. It did not even happen in the last 10 or 20 years. It's beyond 20 years that we've known that atropine can actually slow myopia progression. For some reason we chose not to look at that data. Well, now we're looking at it. But the issue is 1% atropine gives good myopia control, but as clinicians, we all know that it's going to lead to glare, cycloplegia, difficulty reading tiny things, and nobody wants to go through that. So there's been several studies that have looked at different concentrations of atropine. There's a LAMP study, there's LAMP1, that's low concentration atropine for myopic children, myopia progression. There's the ATOM study, the atropine treatment for myopia, ATOM 1, 2, 3, there's a LAMP 1, 2, different landmark clinical trials. But what we now know is, initially what we thought was 0.01% atropine was safest because it caused the least amount of pupillary dilation and least amount of cycloplegia, while still giving clinically significant myopia control. However, when those studies were looked at in the long run, 0.01% atropine is just as good as putting saline water in the eyes. It doesn't do much myopia control in the long run. So what is now recommended is 0.05% atropine. Now, obviously, these concentrations are not commercially available, so you have to have a compounding pharmacist. I'm lucky to be able to have this concentration of atropine. Commercially, you might find 0.01% atropine, or what is recommended now as a standard is 0.05% atropine. Now, it does not mean that patients who are dosed low dose atropine may not still complain of some of the side effects. Now, the word may underlined, because in one of these trials looking at low dose atropine or low concentration atropine, about 25% experienced issues related to glare and cycloplegia. So what was done, or what is recommended, is when you give low concentration atropine, give a spectacle correction that has an add portion. For example, a bifocal or progressive addition lens to help with that accommodation issue that may ensue. And keep in mind, the change in accommodation is about 1 to 2 diopters. It's actually not, most children don't notice it. But to be proactive, give a progressive addition lens with an add of 2 and make it photochromic so that that slight 1 mm dilation in the pupil doesn't cause the sibling glare when they're outdoors under the sun. Screen time. We know that children who spend more time on digital devices will likely develop myopia, and myopia will progress more. What the reason is, we don't know exactly. But the good part is there are now a lot of studies that are looking at the visual environment as it relates to myopia progression or myopia onset in the first place. We know that the intensity of lighting outdoors is different from the intensity of lighting from a digital device. We know that the intensity of light plays a role in the development of the eyes of children, development of the eyes of rhesus monkeys, and in chicks. The exact elements in the visual environment, we do not exactly know what causes that. However, the good news is within the next 3 to 5 years, we would have an answer to this because there are several landmark trials currently underway that will help us know what's going on with screen time and how it relates to myopia. Outdoor time, however, we do know for sure that time outdoors sort of is protective against myopia onset and myopia progression. And lastly, sleep time or sleep pattern. Now, for sleep time and sleep pattern, it's more of an association. We don't have a cause-effect relationship yet. But we know that children who have less than 9 hours of sleep, who have more than 9 hours of sleep, are 41% less likely to develop myopia compared to those who don't. We know that there is a circadian rhythm attached to sleep pattern. We also know that things like axial length and choroid have the circadian rhythm as well. And if there's an alteration in the sleep pattern, there's an alteration in the level of melatonin. Keep in mind, children with myopia have been shown to have an increased level of melatonin. Whether that's as a compensation for poor sleep pattern, we do not yet know. But we know that children who have myopia tend to have higher levels of melatonin compared to those who do not have. So there is something floating around sleep pattern, circadian rhythm, level of melatonin, and the dopamine on the retina that has an impact on axial length change that causes myopia. The exact cause-effect relationship, we do not know yet, but obviously studies are still undergoing, and we should have answers to that. Just like for screen time that we will soon know, we should have answers to sleep pattern very soon. Now, we all know that we should commence myopia management as early as we diagnose the child with myopia. So long as they're still within the age of progression, whether they are progressing that moment or not, you should be commencing myopia management. The question is, when do you stop myopia management? I'd refer us back to the COMET study, which is the collaboration for myopia evaluation trial. Now, what this study did was follow children up for a very long period of time with myopia to see when they stabilized and at what age most of them stabilized. what the study showed was that 48% of individuals or children, the myopia became stable by the age of 15. So less than 15 years of age, be aggressive with myopia management. 77% of myopia stabilized, 77% of children with myopia stabilized by 18, 90% stabilized by 21, and 96% stabilized by 24. Now, if you want to look at this data clinically to make it more relevant to you, reverse the information. What this first point means is that 52% of children are still progressing by the age of 15. 23% of children are still progressing by the age of 18. 10% are still progressing by the age of 21. 4% are still progressing by the age of 24. So you want to carry out myopia control until you've got to this age, 21 to 24, before you can consider pulling them out of the myopia control strategy that you have started in the first place. Now, it's important that we realize that we're not just trying to be savvy or modern by doing myopia control. We're actually trying to prevent potentially blinding complications. Studies by McGullimore shows that for every 1 diopter myopia that you prevent from occurring, you decrease the likelihood of developing myopic maculopathy by 40%. You're also going to decrease the visual impairment associated with uncorrected myopia, improve quality of life, and that person becomes less burden to society due to visual impairment. Now, to wrap this up, I'm just going to go through a couple of about 2 or 3 cases here that just drives my point home. So these are cases that I've managed in my practice. Like I said, I'm involved in, aside from myopia management clinically, I'm also involved in myopia research as well. So the first case would be a 15-year-old female who was referred for myopia management. Her father has high myopia, -6 in both eyes. She spends about 8 to 10 hours on digital devices, 1 hour outdoors, which is quite typical for most modern children these days, but it's not visually good. Her current prescription, her habitual prescription rather, was about -3.5 in both eyes. Psychometric refraction was about -5 with 0.5 cylinder in the right eye, and -550 with 0.5 cylinder in the left eye. Axial length is 26.55, 26.37. This is obviously beyond what we can be comfortable with. She's orthophoric at far, 2 prism diopter ISO at near, has a lag of +1.5 diopters, which is considered a high lag. So near ISO, high lag, long axial length, myopia above 5 diopters, family history of myopia, too much time on digital devices, limited time outdoors. The parents were not so comfortable with the idea of going the contact lens route at that moment, although now she's on contact lenses, but at this time she was not, they were not comfortable with it. So we did put her on progressive addition lenses and low dose atropine, and for 1.5 years she did not progress until they stopped using the low dose atropine. Progression occurred, and then we switched to the center distance multifocal contact lens. Now, second child, 10-year-old, referred for myopia management. Mom is short-sighted, -6. Screen time is 6 hours. Child spends time outdoors, 2.5 hours, more than the recommended even. However, the child's present prescription that they came in with was -15.5 with 2 diopter cylinder in the right eye, -15 with 2 diopter cylinder in the left eye. Psychometric refraction about -18 with -1 cylinder in the right eye, -19.5 with 0.5 cylinder in the left eye. Now, obviously, this child does not fit into the clinical picture of most patients that you would consider suitable for myopia management, because the myopia is already beyond what most clinical trials recommend for. However, there are a few studies that actually show that we could still attempt myopia management in very high myopes as well with good success. His axial length is 29 in the right, 29.03 in the left. Keep in mind, this is a 10-year-old child we're talking about who's still going to grow. And when he grows, obviously that axial length will increase. Now, also at far, 2 prism ISO at near, MEM was 1 diopter. When we dilated, I found retinal lattice degeneration to the trophic holes. So I had referred him first to see a retinal surgeon where he underwent barrage laser. And then a month post barrage laser, we then did put him on low dose atropine and progressive addition lenses, and we followed up 6 months. And for 2.5 years, this child has still not progressed. It's a child that I see very frequently, and his myopia has been stable since then. And the good part of this particular case is it shows you the benefit of thorough examination, co-management with the retinal specialist when you see complications, and the reason why this child should have been managed even before they became -15, because this child did not start at -15. They started somewhere. So somewhere along the line, practitioners had failed this child. So you do not want to start myopia management by the time you're already seeing this and lattice generation. You want to start it earlier to avoid these kind of complications in the first place. And the last case is a 13-year-old female, was referred to myopia management. Father has myopia, has had retinal detachment as well in his left eye. She spends about 12 hours on digital devices daily. I mean, it's very easy to know these kind of kids. They come into the consulting room holding their tabs glued to their eyes. And 1 hour on digital device, 1 hour outdoors. This child is about habitual prescriptions about -2.75 in both eyes. However, present cycloplegic refraction was -550 right eye, -325 in the left eye. Look at the axial length difference. We see that axial length is about 26.02 in the right eye and 25.86 mm in the left eye. We see that the patient is ortho at far and near. BM is about 0.75. Parents were fine with proceeding with orthokeratology, so we did orthokeratology. Decreased the back optic zone diameter to get the treatment zone closer to the pupil, so we could get more of this plus power causes the myopia control effect closer to the pupil to induce better myopia control. And we followed this patient up for years, and there's been no progression. So basically, this is just the patient's topography before orthokeratology, and this is after. So you sort of see the bull's-eye pattern that mimics the pattern of the bullseye that you will see with an orthokeratology lens. Flattening at the central part, stiffening in the mid-periphery, which gives the myopia control effect. And obviously, this gives very excellent form of myopia control, plus the added boost in confidence, because this child no longer wears spectacles to see and has that improved quality of life. All right, thank you very much for listening. I think that brings us to the end of this lecture. Can unmute your mic, and or rather, I'm not sure how this works. Probably you can ask questions in the chat section. Thank you all for listening.
Thank you so much, Dr. Emeka, for this informative presentation. Yeah, I know we have learned a lot. We have a lot to ask. We have a lot of questions to ask. If you have questions, please, you can submit it in the chat box, or you can use the raise hand icon, and I will call you to ask your questions. This is time for question and answer session. Okay, Dr. Emeka, we have a question in the chat box. The first question is, does it mean that every patient with myopia is eligible for myopia control, or are there indications for myopia control?
Well, every patient who's within the age of myopia progression is a candidate for myopia control. I'll take you back to the COMET study that I talked about before. If the child sitting in front of you is less than 15 years of age, you need to remember that in the COMET study, 48% of children had stabilized by 15 years of age. What that means is 52% of children are still progressing. So if the child sitting in front of you is less than 15, you should be doing myopia control. If the child is less than 18, you should be doing myopia control. When you should be monitoring before you step in is above 18, because after the age of 18, by 21, 90% of children have stabilized. So long as the child in front of you is less than 18 years of age, commence myopia control. Now, I'll liken this before I conclude to glaucoma. In glaucoma, we do not wait to see that the visual fields are getting worse. We do not wait to see that the retinal nerve fiber layer is getting thinner. We do not wait to see that the intraocular pressure has gone from 22 to maybe 30 before you decide to start glaucoma management. Why is it that you want to wait when it comes to myopia? For the myopia to progress or to see pathologic changes at the posterior segment before you start doing the intervention. You want to do this before that occurs. So if the child is less than 18 years of age, commence myopia management. But for adults, it can also happen that, yes, they have progressive myopia. So for adults, you might want to do it on a basis of evidence of progression. But less than 18, you don't need any other evidence. Start myopia management.
Thank you, Dr. Emeka. The second question is, okay, this question is requesting if he or she can get the slide after the presentation for further study and referral.
I think this is being recorded, right?
Yeah, it's being recorded.
Okay, so I think it should be available then.
Okay. So the next question is, please, are these myopia control lenses available in Nigeria? I think the person
which of the
about
lenses? The contact lenses or the spectacles?
I think the DIMS and the Stellex lens.
Okay, so DIMS is not available in Nigeria presently. Stellex, we're still hoping that that will come in soon. Hopefully this year or next year, hopefully. But currently, Myocare is available in Nigeria. So Myocare is available. I don't represent the company. I don't speak for the company. But if you reach out to me personally, I can share the details of how you can get the Myocare lens. It's just as effective as Stellex as well.
Okay, thank you. The next question is, after myopia control is stopped, does the patient still use single vision spectacles without hyperopic defocus concerns?
Okay, so I'm going to try to answer this in how it doesn't make sense that you're going to give single vision glasses after you've given a myopia control intervention. For example, if you give the Myocare lens, for example, the vision correction is already at the center. So the patient already has clear vision through that Myocare or defocus spectacle option that you're giving. So there will be no need to be given a single vision lens separately. The only time I think you probably will be thinking about giving a single vision lens would be when you use a center distance multifocal lens. So for center distance multifocal contact lenses, we often give backup single vision glasses because they will not wear the contact lenses 24 hours. So let's say they wear the contact lenses 10 to 12 hours a day. By the time they take it off, then they can wear their single vision glasses. But otherwise, if you're using any of the spectacle options for myopia control, there is no need. If you're using orthokeratology, there is no need. It's only when you're going to use it as a backup option for multifocal, center distance multifocal contact lenses. And oh, sorry, I forgot to mention, for the contact lens options for myopia control, yes, we do have those available in Nigeria, both orthokeratology and center distance multifocal contact lenses. You just have to be taught how to use them before they can be sold to you. For center distance multifocals, you don't need any special training as such. You just have to have a general idea of soft contact lens fitting. But for orthokeratology, you have to be trained, certified to do that. I do represent a company that trains and manufactures practitioners. They're not sponsoring this talk, so I'm not talking about that or mentioning that. But if you reach out to me personally, I'd be happy to train or teach you how to fit orthokeratology lenses. Dr. Franklin, you're muted, so we can't hear you.
Sorry, thank you, Dr. Emeka. The next question in the chat box is, most times, from Dr. Wilfred, he said most times when you give the ad with respect to progressive additional lenses to control myopia progression, patients experience blur while reading. What do you do here? Remove the ad or insist on wearing the glasses?
Okay, so when you give progressive additional lenses, typically the blur that they experience has to do with the walking distance that they're putting those targets or whatever it is that they're trying to reach. So they might have to adjust that walking distance somewhere a bit closer, because typically the ad that we recommend is an ad of 2.5. which means we're looking at a walking distance somewhere around 50 cm. And kids are often used to doing that who have myopia. So we want to reassure them, take it back to a particular range, and then use that. I don't tend to find that complaint quite commonly. It's quite rare. I mean, I've seen it happen, but not very commonly. It's usually adults who give you all the headache about progressive additional lenses. Children are very forgiving with those kind of things, but few of them do report it. And for those who report it, you want to just tell them, move the stuff back to this distance, somewhere around. So what we tell them is make an elbow like that, and then keep the material at that area. Usually they're fine after you explain that to them.
All right. Thank you, Dr. Emeka. Before we go back to the questions in the chat box, I think we have some hands raised. Let's listen to them.
All right.
Dr. Ojobi, favorites, can you unmute yourself and speak? Dr. Ojobi? Okay, Dr. Ojobi is not here. Dr. Ben, can you speak? Your hand is up.
Good evening, everybody. Please, thank you, Dr. Obinwanne. I wanted to just find that based on the myopia you've been able to manage, what's the percentage of the reduction or the progression that was slowed down based on your knowledge? Thank you.
Sorry, I didn't get that. The reduction in the progression of what?
The myopia cases you controlled, maybe like 5% was slowed for the next for the last 2 years, or 2%.
All that.
Yeah, thank you.
Okay. All right. So that'd be an interesting question to answer. And maybe a bit of laziness on my part. So I can give you the crude information and tell you that my patients who have, so first of all, I have data for myopia management dating back to 2016. And as at 2021, when I was doing my research master's, that total number had come up to 400 and something. Now we're likely heading up to 600 and something cases that we've managed so far. But when we reviewed the data back then in between 2021 and 2022, what we have found was children who were compliant with low dose atropine, children who were using center distance multifocal contact lenses, children who were using orthokeratology, hardly experienced any progression. So obviously that goes beyond the 50% mark for clinical efficacy for myopia control. I've had kids who are certain distance multifocal contact lenses, and we actually noticed a regression. Recently, I was speaking with one of my former optometrists who's also involved in research with us now. And we had picked on one case that we had managed with low dose atropine, and we were seeing a regression in the power. Typically, that doesn't happen. However, there are few case reports out there that shows that it can happen, and that happens because the atropine makes the choroid thicker. The thickening of the choroid shortens the axial length. The shortening of the axial length makes the myopia look like it's reducing. The ones that we noticed that progressed more were either those who the parents refused to undergo myopia control, or the ones that were using bifocals or progressive additional lenses for myopia control. So you're likely going to see that, yes, the progression may slow down. It may not be that it halts the progression completely, but there's still be a bit of progression here and there with those kids. So in terms of efficacy, it'd be difficult to give you a number, but definitely better than 50% for most cases. So what I'd usually advise is tailor the myopia management to the child and the individual. Obviously, you want to keep cost in mind, but tailor it to the individual. But in terms of efficacy, for those who've done myopia control, we tend to see very, very good outcomes.
Thank you, Dr. Emeka. We still have another hand up. Dr. Emeka, we can.
Thank you so much, Dr. Obinwanne. So my contribution or comment is earlier on you made mention of restoring the confidence of these patients with myopia, knowing the fact that most of them they keep to themselves, they hardly socialize due to the level of vision they have. So the aim of this myopic management, like you've rightly read out, is to kind of minimize the risk factors that might come along with progression. So I want to ask, with this myopic management, what role do you think that refractive surgery plays when it comes to restoring patient confidence?
All right,
Thank you.
so very good question. But here's the thing you need to keep in mind. Refractive surgery is not myopia control. And there is a reason why refractive surgery is not done for children, except in very special cases. During my residency, my subspecialty training was in refractive surgery. You would typically not, one of the indications for refractive surgery is the child or the individual rather has to be above 21 years of age. The reason for that is because we know that if you look at the COMET study, about 90% of individuals stabilize when you have myopia by 21 years of age. So most of them, only 10% will still be progressing by that age. Refractive surgery, what you're going to do is basically ablate the central around 8 millimeters of the cornea to give clear vision, depending on the amount of myopia that they have. You're not doing myopia control, that's vision correction. However, in terms of confidence boost, in terms of outcomes of mental health, in terms of decreased spectacle dependence or use of contact lenses, refractive surgery has those excellent outcomes. But refractive surgery is not myopia control. But what we usually advise is enroll the child in myopia control up until the stage where they are no longer progressing. By the time they get to 21, 22, you can then have them do refractive surgery. Because even for refractive surgery, there is a limit to which you can correct certain errors. For example, LASIK, the FDA recommends maximum of -12 diopters. If you have a child who's still progressing and goes beyond that limit, obviously they're not going to be able to have that procedure done. So you might be thinking of other procedures like phakic intraocular lenses, things like that. But the idea is myopia control first, then refractive surgery once they've crossed 21 years of age. So refractive surgery gives good vision, but it's not myopia control.
Thank you, Dr. Meka. I think that answers the question perfectly. We will continue from the questions in the chat box. The next question is, what's the time frame to check whether myopia control is working or not? Every 6 months or every 1 year?
Every 6 months. So what's recommended by the International Myopia Institute is follow up every 6 months. However, if you have a child who is a fast progressor, a child who's come up with pathological changes under your watch, you might want to reduce that to every 3 months. But what's recommended is every 6 months. And then once myopia control is established and the child gets out of the range of myopia progression, which would be about above 18 years, you can then change that to once a year. But once they're less than 18 years of age and still actively in myopia management, review every 6 months.
All right, thank you, sir. The next question is, at what power does myopia control management have little or no effect?
Take that again, please.
He said, at what power does myopia control management have little or no effect? At what therapeutic power?
So, well, there's no specific therapeutic power per se, but what we can say is high myopes or pathologic myopes, those who the myopia has become like really high, and maybe one of the cases I showed, -10, -12, -13, and all that stuff. We haven't really studied them because most of the clinical trials you will find for myopia management limits the upper limit to -6. So what happens to those who are -8, -9, -10? We don't really know. So does myopia control efficacy reduce in that population? Possibly. But one of the studies that we like to quote in this kind of cases is a study out of China that looked at partial orthokeratology for very high myopes. So say you take someone who's -10 and you only do -5 correction with orthokeratology. So maybe they have to wear spectacles or contact lenses to correct the remaining residual refractive error. What studies showed is that even for those who had partial orthokeratology, they still had efficacy of myopia control. So should we say that it is less efficacious because we haven't studied it? We can't say that. We just don't really know. But what I tend to use more clinically is center distance multifocal contact lenses in combination with low dose atropine in this population. And personally, from my patient base and from the data that we've collected so far, this seems to work for very high myopes. But in terms of from the low myopia end of spectrum, no, there is no restriction or that says myopia control doesn't work in that area. It's just the high, very high ones that we haven't studied, so we don't really know what happens with them.
Okay, thank you. The next question is, in using atropine, what time is the best used? And also, can you please throw more light on some of the side effects this patient is expected to experience when using it?
Sorry, your voice was breaking at some point.
Okay.
In terms of low dose atropine, what time is best?
Yeah, what time is best to use? And also, can you throw more light on some of the side effects this patient is expected to experience while using the atropine?
Okay, so what's recommended is not to prescribe the low dose atropine at night. But well, we usually just say once a day, but typically we say at night. Some of the effects or some of the things that the child may experience, aside from glare, because the pupil may increase 1 to 2 mm, also change in accommodation, decrease in accommodation because the accommodation sort of reduces by about 0.88 to 2 diopters. But other things that were noted is allergic conjunctivitis. You will tend to see that some kids who are on low dose atropine will report itchy eyes more than those who are not on it. So that's something that you need to keep in mind. So itchy eyes, glare, sometimes blurred near vision, that's something that you need to keep in mind. Another thing that you need to realize is with low dose atropine, it's compounded. So you don't have 0.05% atropine sitting on the shelf for you. You have to have a compounding pharmacist to compound it for you. Now, there's a study by Mark Bullimore and his group from University of Houston in Texas that, was quite interesting because you might ask your compounding pharmacist for 0.05% atropine, but if you actually have the devices to actually check the concentration of atropine in it, it may even be higher than the 0.05. So because it's not standardized and commercially available, and we have to rely on compounding pharmacies, there might be a bit of errors here, which may account for some of the side effects that we see. But the most common would be itching, would be glare, and decreased vision. So to counter that, always prescribe low-dose atropine with bifocals or progressive additional lenses that have transition coating on them. And then previously the HEI is reduced, so antihistamine and cell stabilizer drops for that.
Right, thank
You
you.
can also put it in the fridge, that decreases the sensation.
So the next question is, what's the most affordable myopia control option? An option that the average Nigerian can afford?
Okay, can you hear me? Your voice was breaking there. I'm not sure if it's from my network.
Yeah, we can hear you, sir. So should I repeat the question?
So the most affordable myopia control option would be progressive additional lenses or bifocals. But those are not the most efficacious. Now, I typically have a problem with thinking in that line of let's give the most affordable thing. What we want to do is to give the most efficacious thing. So if what your patient base can afford is maybe progressive additional lenses or bifocals, add compounded atropine to that. So that would boost up the myopia control effect, because it makes no sense taking somebody who's progressing 1 diopter per year, family history of myopia, limited time outdoors, and then all you're doing is giving progressive addition lenses, which would give between 11 to 33% myopia control, which means there is almost a 70% chance the myopia will get worse. So you want to establish something that will be efficacious for the child, not just affordable for the child as well. And also, before I conclude on that point, also remember the impact of environmental changes, proper sleep pattern, decreased screen time, and more time outdoors. These are also options of myopia control, not only just, obviously they have to be done together with a particular intervention, but we shouldn't downplay the impacts that they have in myopia management as well.
All right, sir. Thank you so much. The next question is, what's the dosing of atropine? And does the patient keep using it till they are up to 18 years of age?
So the dosing for low-dose atropine is typically once a day. The time to stop, that's still being debated. There was the ATOM-3 study that showed that after it was stopped, for some kids, they had rebound effects. And that rebound effect caused some changes or progression in myopia. And the problem with that trial was that atropine was stopped abruptly. But we know from evidence that we should not suddenly stop atropine, otherwise we will experience rebound effects. So what's recommended is to taper it off. So if you're starting off at 0.05% and you've used this for the 3 years, which typically is what most of the clinical trials that's recommended by the duration recommended by the IMI for any myopia control intervention is 3 years. So let's say you've used 0.05% atropine for 3 years for myopia control, taper off to 0.025% for a year, 0.01% for a year, and make sure that there is an optical intervention being introduced when you finally stop it after 0.01%. So the idea is to taper off using lower concentrations and switch to an optical intervention. That way we do not have a rebound effect. So 3 years, 0.05%, then 1 year each for 0.025, 0.01%, then switch to an optical intervention, and then that way you've tapered off the low-dose atropine, because when you stop it suddenly, there's a rebound effect.
Okay, thank you, sir. The next question is, when it comes to gender, which of them is at risk of developing myopia?
That's interesting. So, sadly, females. Well, in terms of the number of myopic patients, we see more numbers in males. However, in terms of the severity of myopia, for example, severity or the magnitude would be like -1, -2, you tend to see higher myopia in females. The reason is because during the early stage of myopia development, females tend to grow more rapidly compared to males. Now, because of that early stage development, the axial length, obviously, the axial length change is more rapid in that age population, in that gender group. And that rapid change in axial length at a younger age, because girls sort of mature faster than boys, that rapid change as they approach their puberty stage, rapid change in axial length, that drives the axial length increase from a very early age. They also stabilize first compared to boys, but they just have a higher magnitude. And also we know when we look at certain pathologic changes like myopic maculopathy, for example, we see that the axial length threshold is smaller or shorter for females than it is for males. So for females, at about 25.3 mm, studies report that you might start seeing changes related to myopic maculopathy. But for males, it's about 25.6 or so.
All right, sir, thank you. The next question is, what other eye drop can substitute for atropine?
Well, we don't know of any that's been clinically proven to give the same efficacy that low-dose atropine does. There is pyrazepine, there's even brimonidine that's been studied for myopia control, but these have not been widely studied. Most of them do not go beyond animal studies. Even the recent eye drop that's been marketed, that the FDA has just recently given a new drug application for, it hasn't been approved by the FDA, because atropine is still being used worldwide as an off-label treatment for myopia control. But the FDA has recently accepted an NDA, that's a new drug application, for low-dose atropine. So that new drug that's been marketed that we don't actually know what it contains, and they give like a fancy lab name, it's actually just 0.05% atropine. That's now being studied to get FDA approval for it, because when you have FDA approval, then it can become commercially available with standardized fixed 0.05% concentration. But for now, you still have to source from compounding pharmacies. So it's still atropine. Other pharmaceutical agents, they're neither here nor there. There's also some studies that have looked at scleral cross-linking, just as we do collagen cross-linking for the cornea and keratoconus. The studies are looking at scleral cross-linking for myopia. Again, these are more experimental studies than clinical practice. So keep that in mind.
Well, thank you, sir. The next question is, you talked about outdoor activities under environmental factors. My question is, how exactly is being outdoor preventing myopia?
Good question. Truth is, we don't know. We have theories, but we don't know exactly how. So here's some of the theories. One, we know that the level of dopamine that you get when you spend more time outdoors is higher compared to when you spend more time indoors. Now, we know that dopamine plays a regulatory mechanism or a regulatory role in the axial length increase. So it's possible that increased time outdoors alters your dopamine levels and controls the axial length by that means. It's also possible that the visual experience outdoors, in terms of the intensity of light, signals some changes on the retina that we still don't know yet. There's going to be a lot of, we still don't know this answer, that tells you that, that controls the axial length change. So it might be the intensity, it might be the wavelength of light, it might be the fact that you're not looking at an image from a pixel screen that stimulates tiny amounts of accommodation and triggers choroidal thickness changes. We don't really know. However, I will say this, we will know the answer to this at most 3 to 5 years time. The reason I say that with certainty is because the Meta Lab, previously Facebook, now Meta, released a grant of about $500,000, and they had come up with a device called the VEER device, the Visual Experience, I can't remember what the other E, but reality device. Basically, it's mounted on a spectacle, and it can calculate light intensity, optical distance from objects, wavelengths, basically measure the visual experience and quantify it. And it's just something that's spectacle mounted. And they're doing this research in partnership with the American Academy of Optometry, which that's because I'm part of the academy. That's how I happen to know that, and I'm part of that research. So we would know that in 3 to 5 years time. We would know exactly why. But for now, we just have theories. Maybe it's the light intensity, maybe it's the more relaxed environment, visual environment outdoors. Maybe it's the fact that we're not looking at pixel screens that stimulate accommodation. Maybe it has to do with dopamine. Maybe it has to do with changes or alteration in the level of melatonin. We don't know, but we would know soon.
Thank you so much, Dr. I think the time is fast spent. We'll be stopping here for the question and answer sessions. If you wish to ask the speaker more questions, you can, Dr. Emeka will be dropping his email in the chat box. Please, can you drop your email? Then you can chat him up either through his phone number or email address and ask your questions. He'll be glad to answer your questions, I'm sure. Thank you, Dr. Emeka, for the wonderful knowledge shared on advancing myopia and management technique. Thank you for giving us time to honor our invitation to be the speaker for tonight. Out of your busy schedule, I want to say a very big thank you and welcome. We're ending up this webinar. Thank you. And also, just to inform the House that Dr. Obinwanne Chukwuemeka happens to be one of us, a member of the Optometry Scholars Academic Forum. Thank you, sir. You're welcome once again. Thank you all of you for joining us tonight. We share the recording for today's webinar on our YouTube channel and other social media channels. So once it's available, will inform us on it. We appreciate your input and we look forward to see you at the next event. So stay tuned for our future webinars and events organized by the Optometry Scholars Academic Forum Committee. Thank you and good night.